our ED colleagues do a wonderful job of treating every patient that comes through the door, right? Now, they are faced with the challenge of treating patients with the lowest acuity and then highest acuity, right? And it's a organized, chaotic situation where we do a wonderful job saving lives. New York City sees somewhere around 1 million to 1.1 million patients a year in our emergency departments. My goal is to take some of those patients and bring them to ExpressCare. We've done this with various ways. So the programs I've already spoken about that intentionally looks to get to the patient earlier than when they're making a decision for the ED, right? We also in our format we think about the 911 system because that's where some of the patients come in, and patients come in for reasons that you wouldn't think to leverage ED, right? That could be I have a cold, I have a dental pain, I have a cough, many things that you don't necessarily think is an emergency, but people will call. So how do you defray that? We have what started out as an ET3 program, 911 to telemedicine. Those patients are transferred to us, right? And then we try to take care of the patient and treat and release the patient. If they truly needed an emergency service, we're able to determine that. So it's an emergency medicine doctor that's working with the patient, that's evaluating the patient. We're able to determine what the need is, and maybe they need an ambulance. We'll deploy the ambulance. We have a partnership, so we're able to deploy the ambulance ourselves, or we'll bring them in an Uber. Like we don't need to waste an ambulance trip. The reason we don't want to waste that ambulance trip is it's a response time thing, right? Each low acuity case ambulance responds to, they cannot respond to that heart attack. That's
yeah,
that,
the
right?
opportunity cost.
The opportunity cost is huge. So that is like the critical factor there. So we're able to bring those patients in. We are also like, think about somebody that just went to the ED. At discharge, we talk about the value of something like ExpressCare. We're able to share that. So next time they're able to leverage something like ExpressCare and not come in with the ED. The last thing I would say is maybe that person is in the ED, right? And maybe we should just see them in the ED and have a talk, triage them, and have a discussion with them, and maybe leverage a kiosk and say, you know what, you could wait a little bit longer in the main ED, or you could leverage this telemedicine service that we have that allows you to get connected quicker, get the care, and be on your way, right? And that's something we're investigating and getting closer to doing in virtual ExpressCare and health hospitals. Really, it comes back to the notion of what is the most important thing in healthcare? Is that patient-doctor interaction, relationship, assessment. Everything else, the data, it's for regulatory reasons, it's for payer reasons, it's fluff, right? How do we make that quicker, better, and stronger? That's really what it comes down to and boils down to, and try to cut out everything else that we don't need. Of course, we're going to have all these things because we need it. We have to follow the laws and we have to do the right by the patient, but can we minimize those distractions?